Dr. Jesse. Jesse got his BS in chemistry from Truman State University, and then PhD in chemistry from UT Austin, and did a postdoc at Stanford. And he started his faculty career as an assistant professor at UCSD in 2015, and then rose through the rank. Now he was the promoted to professor in 2021. He has over $50 million of grant funding in his lifetime and more to come. And then 150 peer-reviewed paper, H index of 50, very high. He has some major awards from NIH, such as the NIH Pathway to Independence, NIH New Innovator, and NSF Career Development Award. Research, he is an expert in nanotechnology, chemistry, and imaging. But I want to explain a little bit about the background of my collaboration with Jesse. So about 4 or 5 years ago, Jesse approached me and he had a very simple idea. I thought it was very elegant, also very powerful. He said that one of these days, when patients go to your clinic, your system will take a very cheap transducer, scan the entire mouse in 5 minutes, no discomfort, no irradiation, no risk. And those image information will pop up into some kind of a chart at probing, clinical attachment loss, bone level, biotype, and maybe even identify potential inflammation area. And I was immediately attracted to this idea. And then, so after 3 or 4 years, we finally get to this point where initially we have 2 small grants. And 2 years ago, he got a large R1, and USC is the third component. And then the second component is actually from the Fujifilm, which represented by 4 guests here from Toronto. So there's a manufacturer side, the clinical side, and the engineer side at USC. So we have finally got a second generation of the transducer, which is about the size of a toothbrush. And we are starting to use it. In fact, if you're interested, we are setting up the demo at 2:30 in the dental hygiene clinic, and there'll be some residents and playing around with the transducers. Now, what I think is more important is that I think we're just scratching the surface. I believe the transducer eventually will have many, many more applications. Soft tissue, right? The soft tissue lesion. Imperial side, for example, if you are interested in doing surgery, you want to follow up the healing process of your graft. When you place an implant, you want to know when you load the implant whether there's any bone modification, bone loss. And then even we published one paper where we can use a transducer to image and find the major artery on the palate. So for periodontists, that's obviously something, right? So when you take a graft from a donor site, you want to avoid that artery. So I think that what he is thinking about truly is we're just scratching the surface. And I think that eventually we'll see many more application. And what I would like to encourage you is, if you're interested, you can always send me your idea of how the transducer can apply to your research program, and we'll try to find something, collaborate, and then come up with a project. So anyway, without further ado, Jesse.
Thanks, Casey. It's good to be back at USC. Really has been great collaborating with you over the last couple years. And so today, I'm going to talk to you about some of the projects that we've been doing in this space over the last 4 or 5 years. I'm not going to really talk in a lot of detail. If you have questions about controls, I'm happy to talk about that later, but I want to just kind of give you a big picture overview. I'm also proud, this is only the 4th talk I've given since we renamed the department in light of a $23 million gift from Mr. and Mrs. Lee, who was a very successful businessman in Core DX. And so we're now the Lee Family Department of Chemical and Nanoengineering, actually the only 2nd department at UC San Diego to be named. So my lab these days is kind of a triangle. And so he mentioned that I'm a chemist, and I am a chemist, and about 50% of my lab is still some kind of contrast agents or contrast media. That's not really the focus of the talk today. What I'll be talking about today is more of this side of the triangle, where we're interfacing hardware and software engineering with translational validation. So I have many other projects. We've got imaging for wound care and COVID. But today, everything that I'll talk about is going to be on this axis and focusing on dentistry. So the glue that kind of holds these three sides of the triangle together is ultrasound and acoustic imaging. So what I thought I'd first do is just talk a little bit about how ultrasound works, how it's different from the kinds of imaging modalities that you've seen before, and some of the advantages that it has. So with Dr. Ramon today, we saw some just really fantastic cone beam CT. It's really amazing seeing how that technology has changed. When I was a postdoc at Stanford, those systems were starting to come out, and they're really, really great now. Radiography, of course, a workhorse in the field of oral health. They have a ton of advantages.
Did, but you have to study more.
We all have to study more. So great at imaging hard tissue, bone, dentin, enamel. Ultrasound is particularly good at imaging soft tissue. So ultrasound has incredible soft tissue contrast, and it also has really great spatial resolution at imaging the surfaces of bone. So that's one of the first things that got us interested in ultrasound, is imaging the soft tissue. Second is no ionizing radiation. So the doses have come down over time, but for longitudinal studies, when we want to image the patient repeatedly, radiation dose does start to become a very important consideration. Third is the size of these transducers and the size of ultrasound. So unlike a lot of your conventional radiography where it's difficult to move and you have to have one at every chair, with ultrasound, they're small, they're portable. There's a company called Butterfly where you literally just plug it into your phone and you carry around your ultrasound transducer. So this field, despite being around for a long time, continues to innovate in a really incredible way. So the basic acoustic principle in ultrasound is that we have this little thing, which you've probably seen before, and I'm going to call it a transducer. And what it does is emits and receives pressure waves. And so it has a little thing in there that wiggles, and as a function of electricity, and so you put electricity on it and it wiggles, then it bounces and it echoes off of the tooth, the gum, the fetus, whatever you want to image, and as it comes back, it causes this membrane to wiggle again and creates an electrical current that you can then use to create an image. So this kind of ultrasound is very powerful, and one thing that's particularly important about this kind of ultrasound is the frequency that we're using. So over here, I'm showing the same tooth imaged three different ways. And maybe we'll start at the bottom. And so this is a high frequency image. And you can see this yellow line right here is the biotype, the gingival thickness. You can see the gingival margin really nicely. You can see the tooth surface. And so really quickly, we can look at how much gingiva does this patient have. But if we look at these lower frequencies, 21 megahertz, 16 megahertz, this image starts to become blurry, right? And the reason it starts to become blurry is we're using a longer wavelength. And so this is just a function of basic physics, whereas how much are you sampling per unit volume? And here we're sampling a higher number of times per unit volume. And so we get a much higher resolution image. And so this need for high frequency and need for small things that can access the mouth has really been a lot of the driving force for a lot of the research over the last few years. Another area that we work on is a technique called photoacoustic imaging. And Alexander Graham Bell actually originally described the photoacoustic effect over 100 years ago, but it hasn't been till the last 10 or 15 that it's been used for imaging. And so believe it or not, what we're doing here, rather than sound in, echo, sound back, we're creating sound waves using light. And so most of the time, if I shine light on you or shine light on me, I don't produce sound, right? I get hot. But it turns out that if you move this light pulse shorter and shorter and shorter and shorter, it's that we're talking like really nanosecond long pulses, the heat doesn't have time to propagate. And so what happens to that energy is it basically causes a thermal expansion event that creates a sound wave. And so this is really great because we can put this short pressure wave into our tissue, and based on differences in light absorption, we're going to create these pressure waves which can back propagate. The other thing that's nice about this is we can start to have different channels of information. If you think about ultrasound images, they're generally black and white, right? We have one channel of information. But by using this photoacoustic effect, we can start to have ultrasound created by red, green, and blue light and start to have a lot more pieces of information. So what's doing the absorption in photoacoustics? Well, we can have small molecules, nanoparticles, proteins. As a chemist, I think about this a lot. But more interestingly for this audience is the fact that hemoglobin and deoxyhemoglobin are also really good absorbers, and that we can measure both the total hemoglobin as well as what fraction of it is oxygenated using ultrasound in real time through centimeters of tissue at the chair side. So this is, to me, pretty exciting. Okay, so that's how it works. When I first got into this, the first project I did, it was just a function of, I went to my own dentist. They were doing the probing depth, 3, 3, 5, 6, and then they scolded me. And and I thought, there has to be an easier way. And so, this is the slide that I normally show when I'm not talking to a dental audience, but this community clearly knows the deeper it goes, the less healthy you are. And so some of the problems that at least occurred to me in talking to Casey over time is just variations in the force, the angulation, the site, issues with gingival inflammation. Then talking to Casey, it sounds like this is actually frequently skipped in like your mom and pop dentistry clinics, that a lot of times this charting is just not really even done. And then patients generally don't particularly like it. So I was thinking about this. I actually had a trip to Japan around that time, and we were thinking about what could be a better way to do this. And so we thought, what if we were actually imaging the pocket? And so if we're going to image the pocket, and we want to have the pocket be highlighted, specifically imaging the sulcus, what could we use? And it turns out these adorable little sea creatures, when they get stressed out, they release a cloud of ink, right? That's what squid do. But it also turns out that this cuttlefish ink is full of these little melanin nanoparticles, and that's why they're dark. But it's also a food ingredient. So I was thinking of all the things that I would need to pitch to the IRB to say, hey, I'm going to put this into people. How about something that's already a food? And so that's exactly what we did in this swine model. And so these are the kind of images that we get, where the black and white is the surface of the tooth. These pigs didn't take very good care of their teeth. And so this blue color is some background staining. And then after we give these pigs this oral rinse, you can see the sulcus really obviously highlighted here. And what I love about this image is that if we would have probed here versus probed here versus probed here, we would get radically different probing depths. This also potentially has value in identifying vertical root fractures and identifying these areas where the pocket is particularly large. So we could then, just to help you interpret this image, what I'm now going to show you, and really for the most of the talk, I'm going to show you a plane going into the board, right? So imagine a plane going into the board right about here that really corresponds to what we're doing in probing, right? So here's now the tooth, here's the bone, here's the gingiva, and then this area of red is the equivalent to the pocket depth. So we could look at shallow pockets, medium-sized pockets, deep pockets. We could do a bunch of statistics on this and show that it correlates to the gold standard. But at the same time, I reached out to Casey, and so we got this into JDR. It got, UCSD put out some nice press releases. It was easy to talk about. It's also kind of gimmicky, right? It's also not super chair side applicable. So I showed these kind of images to Casey, and he said, Jesse, that's great, but if you look at this kind of image, I think there's a lot of information there that we don't even need to add anything. Let's look. First of all, you've got the crown, you've got the gingiva, you've got the root, and you've got the gingival margin. Those are always super obvious. The other thing that's always obvious is the alveolar bone crest, and then a lot of times the cemento-enamel junction is quite conspicuous just below the gingival margin. So Casey said, you know, what about if we just forget this photoacoustics for now and just focus on the kind of information that we can get through these ultrasound images? So that's exactly what we did. And this was a project with Jane Law, who's an alumni of UCSD. Let's see there, I've got a picture of Jane. She's now in private practice. Coleman Moore was a PhD student of mine. He's now at Dexcom. And so what we did is we took some of these images. So this is a little confusing. I'm sorry, I flipped it versus that image I just showed you. In this image, the crown's to the left, and now here are the crowns to the right. So there's the gingival margin, cemento-enamel junction, alveolar bone crest. And what we did is we just started identifying these points, X, Y points, and then drawing lines in between them. So we defined this image-based gingival recession as the distance from the CEJ to the gingival margin. This image-based gingival height as the distance from the gingival margin to the alveolar bone crest. Image-based gingival thickness is surface of the gingiva to the bone. And then this image-based alveolar bone level, this white here, is the difference plus or minus of the gingival height versus the gingival recession. So what we then did, so this is simple math. This is easy to automate. This is easy to do. And we wanted to see how does this IGH, this distance from the gingival margin to the ABC, correlate to the probing depth and compare clinical attachment level to this alveolar bone level, okay? So I'll show this slide again because this is kind of hard to hold in your brain. So the study design, we used a transducer that looked like this. It was big, and so we could really only image number 6 to 11 and number 22 to 27. So these are not teeth that have super deep pockets, right, generally. But we did what we could. This goes back to 2021. This was done here at the USC clinic. 10 healthy subjects, 6 disease subjects, but then both of them had about 33 teeth scanned. And we compared these metrics that we determined by imaging to the probing depth, clinical attachment level, as well as standard assessment. I like this slide because it starts to show one of the potential advantages of this technique in terms of monitoring recession. If you look at this slide at the top, here's the gingival margin, here's the CEJ. So the gingiva is clearly in good health. We're covering the CEJ. Here's an extreme case where the gingival margin is now way below where the cemento-enamel junction is, leaving it exposed. Here's another patient where the cemento-enamel junction is exposed. The gingival margin is way low. But these cases right here, where they're right on the cusp, right? If you don't know where the CEJ is, this is a really great way of knowing where is the CEJ relative to the gingival margin and how likely is it to be exposed with recession. So what we did then is compared a couple of these metrics. So on the left is the clinical attachment level assessed by the gold standard. On the right is this alveolar bone level. And so what we showed is that the statistics were quite comparable between these two in terms of stratifying diseased and healthy subjects. We could look for bias through this technique called Bland-Altman analysis and show less than 0.5 millimeter of bias between these two different techniques. Similarly, if we were to compare the ability of this image-based gingival height, so again, alveolar bone crest to gingival margin, how does that distance compare to the probing depth? So PPP is just conventional probing depth, and we showed, again, the statistics both less than 0.05. Without having to put anything into the patient, right? All we did was take this transducer, tap it on the surface of the mouth, and step away. Okay? You might argue that well, Jesse, these images are kind of, yeah, sure, you can see where this is, but can I see where this is? And fair point. So one thing that we did to start to assess that is to look at inter-rater reliability. And so in this case, it was Jane Law and then another resident who both interpreted the images. And so we looked at what's the rater to rater reliability. And really the bias was less than 0.5 millimeter. So we were pretty happy with that, well within the range that would happen with conventional probing depth. However, long term, this is unsustainable, right? To ask you guys to be chair side and clicking, finding these little spots. So through a project led by Bayan Shi, who's a very talented postdoc in the lab, we started using machine learning to automate this interpretation. So here's another great image. Gingival margin's really obvious. Cemento-enamel junction's very obvious. Alveolar bone crest is very obvious. So what we did is started to automate both these 3 points, the distances between these 3 points, as well as the tooth surface, gingiva surface, and bone surface. So AI, as you know by now, works only as well as the training data that you give it. So Bayan recruited 29 subjects. So these were healthy subjects at UC San Diego, imaged 184 teeth, and collected almost 1,600 frames, and then went through on more than half of them and clicked, identified these surfaces, tooth surface, gingiva surface, bone surface, as well as these 3 points, gingival margin, CEJ, and alveolar bone crest. And then used some machine learning techniques along with some really helpful collaborators. I'll skip this except to say that this is kind of similar to the image interpretation algorithms that have existed and are standard, but are also quite powerful. So if we look at a tooth now, here was Bayan's manual annotation, gingival margin, CEJ, ABC. You can see that the algorithm returns values that are really almost identical. So we didn't want to bias ourselves and only show these images that look great. And so we tested this on 250 fresh images that the image had not been trained on. And so what we showed is that the difference between the manual annotation, this is now a histogram, so this is showing how different is the manual annotation to the machine annotation. And the vast majority the difference is very, very low. So 91% less than 200 microns. So 200 microns is about the width of 5 to 10 human cells, right? This is small. So 91%, CEJ, 87%, ABC, 94%. This makes sense. In my experience, in my people in my lab, we always have the most trouble identifying the cemento-enamel junction. So that's why this one is not quite high. But if you look at this range, we're doing quite well in the vast majority of these cases. Same thing with our bone surfaces. So this is looking how well do we identify the bone surfaces. The vast majority are less than 5 to 10 human cells away. Okay, so this was all well and good, but as we mentioned earlier, part of our challenge and a real roadblock in this entire technology is that there are a lot more teeth other than 6 to 11 and 22 to 27, right? And so in order to move this forward, we were fortunate enough to have an academic industrial partnership between the University of Southern California and Fujifilm Visual Sonics to really completely reimagine this transducer and develop a technology that would be even better and access the entire oral cavity. So I'm going to skip over about 3 years of work and jump directly to the punchline. I'll want to definitely acknowledge Drew Heinmiller. Of course, Visual Sonics is a big team, but Drew's been our main point of contact. And what we've had now for about 6 weeks, maybe 2 months, has been a device that looks like this. So the longest dimension is 2 centimeters, but then the width of this is less than 2 centimeters. We can access the entire oral cavity. So this has been really transformative. There's nothing like this on the planet. There are other smaller transducers, but nothing that can image with this high a frequency for high spatial resolution and access the entire oral cavity. So one question we get on this a lot of times is, well, I know ultrasound needs some kind of gel, right? Like you have to put gel on the surface of whatever you're imaging. And that's true. Gel doesn't work in the mouth very well at all. The first studies we did, we actually would squeeze it right onto the gingival margin, and the subject would be left with this nastiness in their mouth. So through some really talented material science work in the lab, we've developed this, basically it's a sock. And so rather than a liquid gel, this is now a solid gel. This doesn't move. It grips the surface of the transducer very nicely. And then for sterility, we use this material called Tegaderm. It's basically sterile saran wrap. It's used on all sorts of wounds that people might have in the hospital. It's been around for 30 years. 3M makes it. It's very routine. It's self-adhesive. So you would just put a little layer of this saran wrap over the surface, this plastic film, and then in between patients, just go ahead and toss it. So what did the images look like? So this is our older transducer right here. And so it images a bigger field of view. So it has more what we call elements, so little bitty individual ultrasound eyes, basically. And so it has a bigger area that it images, but fortunately, to make it smaller and have the ability to access the whole mouth, we only have 128 elements, but fortunately, the business area of most teeth, this distance from the gingival margin to the alveolar bone crest, we can image quite nicely. And what I love is that the image quality is just as good, if not better, with this smaller transducer. So this is both number 23, and you can appreciate the image quality despite the lower size. And then this was our first ever full whole mouth charting using this technology. So we could do both the buccal side and the lingual side for all of these teeth. And as you imagine the software getting better and starting to plot these into what you think of a conventional periodontal charting exam, the parallels between a panoramic radiograph start to become really, really obvious. But what's great is that if you look back on this full charting, you click on any one of these images and you pop out and immediately get this a high resolution image of these teeth. So lots of information and the ability to chart them accurately, I think is only going to continue to get better. This is also, to my knowledge, the only technology that can image the third molars. So here's number 1, 16, 17, and 32. Again, this patient, the reason they're not on here, this patient was a 43-year-old male with graying hair, but no wisdom teeth. And so, but we did recruit some other subjects that still had their third molars. And so the ability to image these was really obvious. We could also image impacted third molars. So this was a subject with a distally impacted third molar. Here you can see number 17. And then when we image, so this is now the occlusal surface of impacted number 17. This is a video, and so you can see the surface of the tooth underneath this is roughly 9 millimeters, maybe over a centimeter of soft tissue. And then this is scanning from the crown up to the root of this same distally impacted number 17. You start to see this hypoechoic, meaning dark, this dark area right here. And so we think this might be a dental follicle, although that's going to require a little more effort to fully tease that out. But I think this starts to illustrate the advantage of ultrasound in that wherever you push this transducer is where it images, and you see the image exactly in real time. right? And so as you move, and you can also see the instrument, right? If you had some sort of instrument in this field of view, you would see the instrument also in real time. One of the arguments that we used to see when we first started doing this is, well, what about imaging mesially? But because of this smaller size, the ability to image buccal, distal, and mesial is increasingly good on this teeth. And then the other application that we didn't think of at first, but is as we rotate this transducer 90 degrees, and now we start to image the interproximal space, right? So this is a different field of view. I'm now looking into the board this way. We don't know exactly what we're seeing, but my argument would be that these structures are the periodontal ligaments. And so this is going to require some careful pathology and some careful models to really understand what we're seeing. But the ability to see at depth in between the teeth in the soft tissue, I think, is really promising. Let's see, what else can we do with this technology? Another project led by Bayan started to look at staging for soft tissue grafts. And so when these grafts are done, typically taken from the PMM, the soft tissue on the roof of the mouth, there can be a risk of sectioning the greater palatine artery. And so the vasculature in the soft palate can be difficult to image with conventional technologies. And so what Bayan did is use Doppler ultrasound, which looks at movement, right? And so if you see pixels in the next few slides that I'm showing, blue indicates movement away from the transducer, red indicates movement towards the transducer. So don't think about this as being oxygenated or deoxygenated tissue. So the acronym is BART. But what Bayan showed is that in 5 different subjects, in each of these cases, she could really easily image the greater palatine artery. And we know it's the greater palatine artery because when I show you the video, you're going to see it sitting there beating. And we can correlate the beat to the ECG of the subject. There's a couple different ways of imaging. One is what's known as the short axis. So if this is the artery, she's cutting it along the short axis. She can also image along the long axis and look at this artery in 5 different subjects. So the point of this was not to really, this was to assess generalizability, right? Is there just only one person's anatomy that we could catch this? Obviously, an N of 5 is good enough to publish a paper. It's not enough for broad clinical acceptance. So this is also ongoing. But I think what's nice is that when I click this video, there it goes. So you can see this beating, right? Let me start that over. So this is sped up 5 times, but when I hit go, you'll see the artery beating. You'll see the surrounding hard palate. You'll see the PMM. You'll see the gingival margin. We'll see the tooth surface, all in real time. So she's basically scanning from this area here over to the tooth surface. And then we can digitally stitch these together and start to have a pretty decent map of the hard tissue, the vasculature involved, and start to get these distances from the greater palatine artery to the gingival margin to start to understand exactly where dissection should be done, where's the right place to take these grafts, and what areas to avoid. Another technology or application led by Tamer Abdelrahim and the group is starting to look at bone loss. And so I've only started to learn about bone loss, but my understanding from Casey is that by the time it starts to get to this green circle or red circle, it's really too late. And that these are really difficult teeth to treat, but that if there was a way to quickly see very small levels of bone loss, to monitor response to therapy, to look at differences between teeth, that this could be really powerful. And so Tamer and Casey worked together and created this swine model. So what we're doing here, this is a swine model. The gingiva has been resected to expose the bone. So this this green dashed line is the bone level of baseline. Each image here, the exact same tooth. So Casey came down to UCSD, and what he did then is started to remove a little bit of bone and we imaged and took a photograph at each time point. And so what you'll notice comparing this line is that this yellow line gets bigger and bigger and bigger as he removes more and more of the bone as a model. So we could take a picture, interpret that image, that photograph, as kind of a surrogate for what the clinician might do in terms of visual inspection of bone loss. And then we could collect an ultrasound image. To make sure we stayed in the same plane, we added what are known as fiducial markers. So these are just things that help orient us in our image. And so by adding these two, these are basically ball bearings, we could make sure we stayed in the same plane as we image this tooth over time. And so here's our bone level, and you can appreciate that it's dropping, dropping, dropping. And so by doing this with multiple swine, we could start to understand how well does the bone loss measured by optics compared to the bone loss measured by ultrasound. We show good correlation, but more importantly, that we were detecting bone loss down to less than 100 microns. So very, very small levels of bone loss that could be detected in real time, longitudinally, and really good inter-rater reliability as we compare this to different examiners. So this is another area that we're really excited about. Of course, the last thing that we need to do on this is compare it to X-ray and radiography, and that's ongoing. Let's see, I'll close with just a little bit of what we can do using photoacoustics again. So coming full circle, we started with photoacoustics, and maybe we'll end with photoacoustics. So this kind of combines these three different sides and starts to use a little bit of chemistry and contrast agents. I've been working on this protease for a couple years now. Porphyromonas gingivalis excretes the gingipane proteases. This is one of the keystone bacteria in periodontal disease. If you look at PG, it just kind of looks like a mean bacteria. It's got these little horns on it. And so what it does is it expresses this protease that cleaves after either a lysine or an arginine. And so they call that KGP or RGP, and there's two different kinds of RGP. And what we wanted to do is to start to image this gingipane as a surrogate for the bacteria in the mouth. The other reason, and the reason that we could get this funded actually, is that there a few years ago was a really high-profile paper in Science Translational Medicine by Domini and Potempa showing this relationship between gingipanes and Alzheimer's disease. So they went through, they created animal models, they gave these animals bacteria in their mouth, they watched the bacteria express gingipanes that got into the brain. But more importantly is they looked at this human subjects data where they compared both RGP gingipane and KGP gingipane in the actual brains of Alzheimer's disease sufferers and showed this upregulated expression in AD brains and then correlated that to tau load. So this indicated not just some kind of activity, but more of a functional relationship. So of course, at this point, everything has been linked to Alzheimer's disease, but we wanted to develop an imaging agent that could be used both chairside to diagnose which teeth were infected by Porphyromonas gingivalis, but also could potentially be used in the brain to guide the development of drugs that treat gingipanes. So again, a project led by Coleman Moore in the group developed this molecule. I'll probably skip over how it works here, except to say that you have two dyes, two absorbers that like to sit on top of each other when they're close together. And when they're associated with each other, making a dimer, they're bad at absorbing light. But as this cleaves and you make your protease cleavage section right here, protease is just a protein that eats another protein. These things no longer dimerize, they can come apart, they can start to absorb light and turn on this photoacoustic signal. So Coleman was very thorough and tested these with bacteria, both PG and F. nucleatum, which is another anaerobic bacteria used commonly as a control. And so what he showed here through these really important controls is that if you had just the broth, this is the background activation, this is low. If you grow the bacteria in the broth, signals low. You look at F nucleatum, signals low. Porphyromonas gingivalis with an inhibitor is low, and only the PG in the presence of the all of these have probe, but only PG turns on this signal in a really obvious way. We could correlate this also with the absorbance data as a sanity check. And then looking at a swine model again, we wanted to say what's the lowest amount that we could detect, the lowest amount of gingipanes that we could detect, and these were low nanomolar, so tens of nanomolar of gingipane that we were not just detecting in the sulcus, but we were imaging in the sulcus. And then moving back to the Alzheimer's perspective, we started imaging these in the brain. And out of respect for your time, I'm going to skip most of this except to say that we are having another paper coming out soon that shows that we can image these gingipanes in the brain of intact living mice. So that's great. I guess then the last thing that I'll mention that photoacoustics can do, and I mentioned this earlier, is this ability to quantitate both total hemoglobin and oxygenated hemoglobin. So the reason this works is that you have two equations, two unknowns, right? So if we look at absorbance at 700 and 900, it's a function of the addition of the oxygenated curve and the deoxygenated curve. Same thing at 700. It's a function of the addition of the two. And so this is the same way that a pulse oximeter works, right? You shine two different colors of light, you look at how much is absorbed, and you quantitate which fraction is oxygenated. Here, we're using the photoacoustic signal as a surrogate for that absorption. This is well established, common in the field, but also really, really powerful. Because unlike a pulse oximeter, which is going to give you a bulk measurement, and that you have to do through a trans configuration, right? You have to pass light through a finger, through a toe, through an ear. Here I take my transducer, wherever I stick it, I get a 3D map of tissue oxygenation. So this is now a rabbit model. And so if you look, there's the front incisors, these two teeth, you can appreciate this hyperechoic region. And what we did is we turned the oxygen that this rabbit was getting up or down. And so you can see this at 100% oxygenated, or 100% oxygenated, this animal has a lot of red signal, 5% oxygenated, a lot of blue signal. This was just a sanity check that we were imaging what we think we were imaging. We compared this to a gold standard to, again, as a sanity check, but then more importantly to this community, we created a ligature model. So we took a little string, basically, we soaked it in Porphyromonas gingivalis, we tied it around the tooth, we let this animal develop periodontal disease, and then we showed that there was a statistically significant lower SO2 value in this animal with inflammation. So you might think, why do you need to do imaging? I look at this tooth and I see that it's inflamed. That's true, you see that on the surface, but you don't understand the map of this, you don't understand the interproximal inflammation. And so imaging this inflammation, I hope, will be really useful to this community in assessing their patients. So with that, I hope these were useful. I hope that I convinced you that ultrasound and photoacoustic can be used chairside to identify dental landmarks, imaging biomarkers, and the use of this as an alternative to invasive charting. These novel engineered transducers can access the entire oral cavity. We can image perfusion and oximetry without any contrast agents. And we can also do molecular imaging of targets. So moving forward, part of what today is, we kind of were celebrating the fact that we have finally built this really small transducer. We have it here at USC. It's operable. Anybody can learn in about an afternoon how to use it. So what we want to do going forward is this automated image analysis in real time. We want to use this perio probe for Doppler and photoacoustics. So these first two are kind of my job, right? These are the technical engineering challenges. But then some of the questions that I have and that would love to welcome collaborations on is imaging bone changes and soft tissue changes like biotypes, pre and post implants. We haven't done anything on implants yet. I think this would be really useful for that. Imaging to complement pathology, to understand and differentiate oral lesions. Full mouth charting as a function of periodontitis. We haven't looked at the full mouth for some of these chartings. Looking at peri-implantitis, other inflammatory situations where we would want to quantitate this. Gum grafts, guiding, planning follow-ups of gum grafts. Cosmetic dentistry, measuring bone movements during endodontic treatments or excuse me, orthodontic treatments to look at movements of the teeth and movements of the root. Every visit, really, we could image this patient every visit. And then molecular imaging of bacteria and fungi in the mouth. And then I want to just call, for those of you that write grants, that have time to write grants, there's a special call out from the National Institutes of Dental and Craniofacial Research seeking applications that enhance the accuracy, detection, diagnostic of oral lesions and inflammation by advanced imaging technologies. And I promise I don't have an inside track at NIDCR, but if they were to write a grant specifically for me, it would be this one. So welcoming opportunities to collaborate on that call. Again, I want to thank everybody in the group who did the work. Again, Casey and Drew and everyone at Visual Sonics for such a fruitful collaboration. The Ostrow School of Dentistry for the invitation and these sources of funding.
US 18, US 1, ultrasound. So now we open for questions for people. So maybe I'll start with this. So, I mean, because in your last slide, you're talking about oral lesion. So,
from the technical perspective, the ultrasound imaging, what is potential for ultrasound imaging to identify soft tissue lesion, like in the oral cavity, like leukoplakia, hematoma, whatever?
Sure. I mean, I think the first thing that we would do is you would look at anatomy, right? Like what are the dimensions of the lesion and how is the involvement with the basal layer? The second would be to look at this hypoxic status, right? Most cancers are hypoxic. And so photoacoustics would be a way of doing that. Ultrasound would look at anatomy. And then you could start to look at other things. There's compressibility. So there's a variety of ultrasound techniques to look at how squishy a tissue is. And so those are some of the first three that I would use.
But what about the if you apply some kind of staining technique to differentiate the oral lesion, that should be area.
That stuff works great in mice. It's just harder to move that to patients
because of the FDA.
However, if you have something that is already FDA approved and that differentially binds to a lesion that happens to absorb light, that's the easy win.
So,
right?
May I ask you a question? So, is it difficult to get acceptance by FDA if you have the antibody-based conjugated fluorescent probe? Is that
They would consider that a new entity.
So it's very difficult to go through.
People do it. It just costs a lot of money and a lot of time.
Right.
So yeah. So the best is like, that's why we looked at those disclosing tablets a couple of years ago, because those disclosing tablets, they're already FDA approved. You just have the patient chew it. So like that kind of stuff that's already there is the easy win. But if we can raise money and start a company, you can
we can screen a whole bunch of available or already approved dye to see which one happen to differentiate the oral lesion and normal tissue. It's possible, right?
Absolutely.
You can screen it. Yeah. Okay.
Thank you, Jesse, for this great lecture. Yeah, I'm using ultrasound for the last maybe 4 years since Butterfly came, and I have another type now. I think about ultrasound is underutilized in the industry. I thought about it like is a 4D rather than 3D because of the dynamic nature of this device. But I have some questions now about your machine and the technique. Um, how many megahertz this small device you are
40.
using? 40?
Yeah,
Um, how many frames per second can scan?
hundreds.
100.
Very fast. Yeah.
It's
I
good.
think 300 is the upper range of standard mode. There's a specialty mode you can go up to 1,000, but like, are there situations where you would need faster than that?
Yes. How about the maximum depth you can go?
Maximum depth is a function of center frequency. These are generally about 2.5 centimeters.
And the last
Yeah.
question is this device still using grayscale of 256 levels or it can go up?
Yeah. Yeah, I think the default output is 256. It's an 8-bit image.
Is it
Yeah.
is it one day might be go to 1024 or more, you think?
Yes, that you could do that. I don't know what that buys you necessarily.
You know, in the oral cavity, we know the more likely, more resolution we have, or more grayscale, we might be able to identify certain tissue, especially in soft tissue scanning with oral
Yeah.
lesions.
Okay. Yeah, this would be a question with it to talk with our collaborators, but 10 to 8, I mean, that's just going from an 8-bit image to a 12-bit image to pick up 1024. So it should be possible. But resolution largely is a function of the center frequency of the transducer.
Okay.
I hope we can talk later. I'm curious how butterfly has worked for your in the mouth.
Yeah.
I mean, it's a
Oh,
big transducer, right? But
No,
maybe
no,
in the
I
mouth.
use in the mouth now another one actually. It's
Okay.
2.5 centimeters, the Clarius one,
Okay.
which is at 20 megahertz, is not for it, but for what I use is great. And I'm telling you an experience. For example, we have two patients at the same day in the oral medicine department. They both have an flora of the mouth, melanotic, looks like lesion. To do a biopsy or not, we scanned both. One of them was sure not to scan. It was showing amalgam particles deep. So the amalgam tattoo. The other one, we didn't see anything. We took a biopsy. So it has some really great use sometimes inside the mouth. We see different lesions in the mouth. It helped me actually to do one small surgery to remove salivary gland, calculus in the submandibular gland. Yeah, ultrasound can be really very beneficial in the dental field if it's utilized right. The problem is to find real good education how to use it.
I couldn't agree more. Yeah, that's why we're at a dental school.
Thank you.
Thank you. Fabiana, so can you pass it to me?
Hi.
Hi.
I just wanted some clarification on the mesial and the distal surface. Can you actually measure get the same measurements from the crest of the bone on the mesial and the distal, the same way you do on the lingual and on the buccal?
Good question. The short answer is I don't know because
Oh.
we've only had this device for a few weeks. It's got to be a function of angulation, right? So you've got to have that angle hitting the mesial and distal side of the tooth. What we can't do is image through the tooth, right? Like, and so
Okay.
that's just a deal breaker. But having this right angulation, we have started to pick up mesial and distal measurements that are by far better than what we could do with the bigger device.
Oh, okay.
Yeah.
That was
So the
just-
right way to answer that question is going to be have, somebody do the probing and then again compare it to our measurements and
Okay.
see that we're actually picking up what we think we're picking up.
Okay. Because I was thinking like the need for crown lengthening after you do a preparation. Because we go by X-ray, how far are you from the bone? If you could like actually use the device to measure from the end of the prep to the bone, so you would have a more accurate measurement instead of just base yourself on the X-ray. Yeah. Okay.
patient has a fracture, have to decide whether to do surgery to expose it and remove the bone to expose the front. A lot of time we do it kind of in like based on our clinical experience. But having this, you can see it's like where's the bone, where's the fracture line, and that's it.
Okay.
But you have to be able to detect all three, like 360 degrees, to say yes.
Yeah.
You need to do surgery, or you can go ahead and do your restoration without surgery.
Yeah.
That happened every day.
Yeah. I think, you know, I'll be the first to admit that we're not out to replace radiography. We're not out to replace cone beam CT. I mean, just like you don't do cone beam CT on every patient, right? But there's a select subset where it's like, wow, this is really the right tool for this job. I think there's going to be applications that come out in the next 2 to 10 years that are like, this is why would I do anything other than ultrasound for this application? So, and that's part of where I mean, you can see we're kind of like not quite spitballing, but we're like, well, let's try this, let's try this, let's try this, and to see what are those top 2 or 3 applications. Yeah.
Whatever something can go down.
Anything else? Oh, yeah.
The probe that you generate use the Sci5 that the probing the ginger pain. How
Yeah.
specific is and that the saliva has so many proteases they don't really chew you probe.
It's shockingly selective. So we've got a really talented collaborator at UCSD who his whole thing is like finding substrate sequences, and he uses mass spec. So he basically takes thousands of different sequences, dumps them together, and then challenges them with different matrices, and then does tandem mass spec and see which one remains intact. So picking that substrate is the magic. And so I don't know, this technique has been pretty good.
Can you actually quantitatively determine the bacterial load you are seeing?
So to some extent, yeah. So Casey would do PCR to quantitate the load, and then we would do imaging. The correlation coefficients were like 0.7, 0.8, so okay, yeah. The thing that surprised me is like how you'll have a patient with perio, but then this tooth will have a really high load of PG, and the one right next to it will be like log orders lower. I find that really fascinating.
Well, it's supposed to be size specific.
Yeah. Yeah.
So ideally you can repropose the put a sequence into it and then use it for other.
Absolutely. Yeah. So we have a whole bunch of stuff I didn't talk today about Candida and particularly C. auris. But yeah, so like AA, isn't denticolum one? Yeah. These other bugs, if they produce a protease. Yeah. Cool. Well, thanks everybody.
Right. So once again, if you're interested in joining us for discussion, exploring collaboration, 4 o'clock, we are meeting at what room is that? 4242, 4342. Yeah. So anyway, so thank you very much. Thank you, Jesse.